So let's start with case number 1, premenopausal woman N0. She's a 43-year-old premenopausal woman. She's a teacher, and she had the following clinical features. In November 22, right side breast cancer, no special type, lumpectomy with sentinel node, tumor diameter was 19 millimeters. None of the 3 sentinel nodes removed was involved with tumor cells, no lymphovascular invasion, and the grading was 2. ER and PR highly positive, HER2 negative, and the Ki67 is 15%, which at least in many of our centers is routinely done, and that value of 15% is kind of at the edge between luminal A and luminal B. You might know since many, many years, we try to define, or additionally, not just by the genomic, but also by the clinical and pathologic features, what luminal B and luminal B, A and luminal B is. So Ki67 is kind of at the border. She had breast surgery. She had adjuvant radiation of the right breast with a boost of more than 50 grays. So in this very common case, what would be your decision for systemic treatment considering this clinical scenario? So is it chemotherapy followed by endocrine therapy, the more or less the more aggressive approach? Is it ovarian function suppression plus endocrine therapy, so which is endocrine therapy for premenopausal patients? Is it endocrine therapy alone, which in that case might be either ovarian function suppression or tamoxifen, because obviously aromatase inhibitor in a premenopausal patient is not a good approach. Maybe you're not sure, you need additional information. And the next one is that, this is a case in which you or I would request a gene expression signature to get more clarity on the risk and the treatment decision. So please decide between chemo, ovarian function suppression, endocrine, which is the maximum endocrine therapy alone, which might be mostly tamoxifen, not sure, or you need an additional gene expression profile. Please. I wait for your signal and then we will discuss the further follow-up here. That's good. I like it. I mean, this is perfect. So most of you, which in Germany at least is enough to build the Bundestag, because 56%, the majority, also request a gene expression. Some of you are not sure, which is perfectly fine. So this is why we are here today. And let's see what the following is. And I have to go back to the slide. So again, 43-year-old, so premenopausal, 90 millimeter breast cancer, node negative, G2, ERPR positive, HER2 negative, Ki67. So this patient received an oh, excuse me, I did something wrong. I have to go back. Can you see it again? Yeah. So yeah. The EndoPredict of this patient is low risk, which means that the patient has an exact calculation. And this is what I like about EndoPredict, because I liked it from the very beginning. It gives us a very clear number with which we can talk to our patients. So the likelihood of distant recurrence within years 0 to 10 is 8%. Absolute chemotherapy benefit at 10 years is 2%. And likelihood of late distance recurrence within years 5 to 15, because that is the time point at which usually we stop endocrine therapy, is 6%. So this is always provided that we give the patient an adequate endocrine therapy, which mostly I think is tamoxifen. For some of us, including me, I would even go for ovarian suppression, function suppression, and either tamoxifen or aromatase inhibitor. And this is all covered by the guidelines. So I think this is quite an important point to make here, because now we have very clear numbers. And the next one is, so now you have the result. And therefore, again, the question, what is your choice in this patient? What would you advise? Is it chemo followed by endocrine? Is it ovarian function suppression and endocrine? Or is it endocrine alone? Which endocrine alone mostly is tamoxifen? Please vote now. This is an extremely nicely splitted vote because this is what I see all over the places. So yes, the majority is endocrine alone, which is I can perfectly live. Now, for those of you who decided for ovarian function suppression with endocrine, I think you are in a very good company, together with me at least. So in this case, I am in a minority. But we are all agreeing that chemotherapy is not needed in this patient. Now, the data which are coming from most of our studies with multi-gene assays are from the era in which, in premenopausal patients, mostly chemotherapy was done, and if endocrine therapy was done, it was mostly tamoxifen. Now, you have seen that this patient has quite a risk of later recurrence. And I think, this is what I think, and we have some data from text and soft, which we're not doing a multi-gene assay, to tell such a patient, if she's asking us, what can I do to reduce that slightly increased risk for later recurrence? And I think what we can tell the patient is, okay, then we can go for the full endocrine combination, which is ovarian function suppression with endocrine therapy. But again, this is something we can discuss at the end. So perfect. I like very much this result. And I think this is, up until now, a very nice closure. This is not a final closure, the closure of this case. Okay, now let's go to the next one. Yeah, so the systemic therapy for this patient, as you see, she decided to go for tamoxifen since January of 23. I talked to her about side effects. Obviously, if you combine it with ovarian function suppression, she will have more side effects. So tamoxifen is something which these patients are dealing with quite, not easily, but they cope quite well with the side effects. Okay, now, supporting data. Because that was always for all multi-gene assay. When we started to do multi-gene assay, we did it mostly in postmenopausal patients. So in premenopausal patients, there were increasing knowledge from different studies, as you can see here. And this is a quite recent one from Dr. Constantinidou from the Clinical Cancer Research this year. And what you very simply see here, at the 10 years median follow-up, those who have an EP clean low risk are doing excellent. And those who are having an EP clean high risk have 24% distant recurrences. So distant recurrences is something of which patient can and probably will die. Even after metastatic disease, there is quite a few of therapeutic options. So the most important message for the patient here is, even in premenopausal patient, we have an excellent knowledge, we have data, and we also can recommend the EndoPredict because it's an excellent factor or an additional tool to really assess the risk of the patient. And with a risk of 24%, obviously, the patient is asking us what to do. So in those patients who are at low risk, the majority in this case, we can tell them, well, your risk is less than 5 or less than 4% at 10 years, that's fine. And for those other patients, obviously, the major question is what to do, being it either chemotherapy, being it either prolonged ovarian function or prolonged endocrine treatment, or the combination with ovarian function suppression.